Dear ICOI colleagues and friends, please allow me the opportunity to introduce myself. I first graduated in 2004 from the University of Adelaide, and I have been treating patients as a prosthodontist since 2012 in Perth, the state capital of Western Australia. My clinical interest has been the management of the severely compromised and missing dentition with implant-supported solutions. I have focused on what I like to call advanced rehabilitation for the last 10 years. I would like to extend my sincere gratitude to the ICOI Scientific Committee for granting me this opportunity to discuss a topic of interest to me titled Immediate Rehabilitation of the Severely Atrophic Maxilla, utilising extended length subcrestal angulated implants. It is my hope that through my presentation I can inspire and enlighten all of you by showcasing advanced engineering and clinical achievements. The management of the severely atrophic maxilla requires a high level of surgical and restorative competency in order to provide the patient with a definitive prosthesis that attempts to mimic the natural feel, form and function of the natural teeth, creating aesthetic, phonetic, functional, cleansability and longevity outcomes that we aim are in comparison to natural teeth. The use of the ELSA implant, which I look forward to describing to all of you soon, provides the clinician with additional options to assist in achieving desirable outcomes and improve the patient journey suffering from severe maxillar atrophy, and provides them with an alternative to a complete tissue-supported prosthesis. There are a number of influencing factors that the clinician must consider in order to devise a suitable treatment plan to satisfy the patient's chief desires. Let me walk through some of those factors of consideration for a patient in need of a full arch reconstruction. For the clinical factors, the quality and quantity of the hard and soft tissue remaining is the most critical consideration. If there is an optimal volume of bone, then one of the several options could include a biological conservative option, such as an FP1 bridge or a gum set ceramic. If there is a complete absence of bone, then zygomatic implants are likely to be required. If the patient's volume of bone is in the middle between optimal and absent, the patient can either choose to have bone built up to create a smaller footprint prosthesis in many cases, or accept the volume of bone as it is and likely reduce the level of convexity and simply replace what is missing. All options can be favourable, and it is up to the treatment plan journey and discussion with the patient to determine which option and pathway is best for the patient. Here we can see a patient who presents with deterioration of the dentition and a low strategic value of the remaining teeth. The volume of bone was favourable for a gum set ceramic FP1 prosthesis. An alternative solution would have been the removal of the bone and fabrication of a historically acceptable aggressive all-on-4 solution. This would have increased the biological cost and footprint of the prosthesis and reduced the aesthetic outcome in comparison to a FP1 bridge. If patients have lost a considerable volume of bone, where the volume of bone is in the class 3 to class 5 zone of the Kaywood and Hayward classification, then graftless or grafting considerations are necessary. In some circumstances, the acceptance of the current bone level is in the patient's best interest, resulting in a prosthesis that replaces the teeth and soft tissue. And sometimes, reconstructing the missing bone is deemed more appropriate. These decisions are greatly influenced by the patient's age, level of motivation, their risk factors that can have a negative impact on healing and integration of the implants and prosthetic materials. Also, your level of skill and past reconstructive experiences, whether they have been positive or negative with a particular type of reconstructive process, your personal interests and biases, as well as the costs, which include biological, distress, and time. Biological cost will include the price the body pays for the treatment, how much tooth tissue, hard and soft tissue needs to be removed or relocated to achieve the desired outcome. Distress cost is how much emotional energy and disruption to the patient's quality of life is expected for the proposed treatment plan. Once I have considered all the factors on the right side of the circle, I like to amalgamate the decisions and outcomes all together to help devise a suitable solution. I specifically like to determine what the end product is going to be and then work backwards from there. I will consider what type of prosthesis to provide the patient, and then I'll determine what am I going to do during the healing phase, the initial healing phase. I consider the laboratory support, and most importantly, consider the biomechanics so that what I provide the patient actually works. Biomechanics is a critical factor, of course, when it comes to full arch rehabilitation. Biomechanics encompasses all the factors that the clinician needs to take into consideration when designing, installing and maintaining the full arch maxillary prosthesis in order to achieve a long-term successful outcome of the mechanical entity within the biological environment with the lowest risk of complications. All of the factors that constitute the principles of biomechanics are to be carefully understood, respected and executed correctly to achieve the desired goal. Management of the biomechanics is the key to success. It ensures the force stays upright and bear the forces that it was designed to be subjected to. Please forgive me as I only have time to discuss two factors relating to biomechanics. Firstly, the implant number and implant location. It's appropriate to place anywhere between 4 and 6 to 7 implants for a full arch implant supported reconstruction. And numerous factors do come into play to determine the number the clinician believes is best for the patient. The separation and location of the implants is important. For all reconstructions, a favourable AP distance is required in order to reduce force magnification and to provide the patient with a full arch dentition. The position and number need to be in harmony with the prosthesis in order to achieve success in all the parameters as well. Each prosthesis needs to look nice, be easy to clean, allow appropriate phonetics, be comfortable and function for a very long time. Bridges of any size will break down or have complications if they have not been designed properly. If there is a biomechanical or mechanical failure, the system will fail at its weakest link, which can be anywhere between fracture of the prosthesis material to bone loss to implant failure. For this reason, understanding the properties of the bone, the best location and size of implants, and the suspected forces the system will be subjected to is critical to long-term success to avoid avoidable unfavourable outcomes. The first subcrestal angulated implant was a zygomatic implant, first placed by P.I. Brainemark in 1991. In 2004, Professor Dalhouse, a prosthodontist from Johannesburg, and colleagues Dr. Boyce Varley and Mr. Graham Blackbeard, a mechanical engineer and founder of Southern Implants, drew influence from the zygomatic implant and developed an implant with a 12-degree subcrestal angulation correction called the coaxis implant. The implant design aimed to mimic the small disparity between the long axis of the root and crown of maxillary anterior teeth. The dual axis implant fixture is available in 12, 24 and 36 degree angle corrections and has been used extensively to deliver biomechanically advantageous screw-retained prosthetics for single, fixed partial dentures and full arch prosthetics. They have assisted to reduce surgical and prosthetic complexity, improve the passivity of fit, and simplify prosthetic fabrication steps, and in many circumstances, help avoid the use of angulated multi-unit abutments. When you have optimal maxillary bone as shown in the top OPG, 4 implants can provide the required AP spread to support a full arch prosthesis. When the bone is lacking posteriorly, as shown in the lower OPG, a reasonable AP spread of at least 20 millimeters is unlikely if the implants are only placed anteriorly. This will result in the fabrication of a shortened dental arch and not a full replacement of the maxillary arch. The remaining volume of residual bone does not negate or reduce the necessary full arch biomechanical requirements, especially in relation to the AP spread of the implants. If you have bone or if you don't have bone, you still need a maximum AP spread. You either consider grafting the bone or consider anchoring the implants in a remote site using zygomatic implants, pterygoid implants, or ELSA implants. so the AP spread is always optimized. The ELSA implant is the big brother of the coaxial system. The lengths range from 18 to 26 millimeters. The crest configuration is an external hexagon, 0.8 millimeters in height and 2.54 millimeters in width. The subcrestal angle feature is 24 degrees or 36 degrees. These configurations allow dramatic accentuation of the osteotomy angle when required to broaden the distance between the anterior and posterior implants. Let me now show you what the ELSA implant can provide your patients that will allow you an extra option or ace up your sleeve to satisfy the principles discussed to achieve a desirable implant-supported prosthesis. In the severely atrophic maxilla, an axially positioned implant posteriorly has a low probability of achieving a favourable primary stability to assist in immediate loading. The conventional implant, which is tilted in front of the sinus cavity, often leads to an inadequate amount of spread. For appropriate posterior support, the options will then be a zygomatic implant placement, pterygoid implant placement, and now the ELSA implant placement. The ELSA implant is a specialized implant correctly designed to help bridge the gap between what tilting conventional implants are capable of and when only zygomatic or pterygoid implants are indicated for immediate or conventional rehabilitation of the severely atrophic maxilla. Following partial and complete edentulosum, reduction of bone volume and density is highly probable, and over time, the horizontal and vertical dimensions of the ridge may reduce, subsequently reducing the number of options of where to position implants. I have labelled severely atrophic maxilla for this presentation with the following criteria: to need augmentation of the ridge or sinus or both at the same time as implant placement, or the use of zygomatic implants to successfully provide the appropriate support for a fixed prosthesis with favourable biomechanics. The ELSA implant provides its greatest benefits to a full arch reconstruction when the sinus has pneumatized to the canine zone and anterior maxilla, and when the use of a graft-less all-on-4 approach produces a poor AP spread. The placement of the ELSA implant is completed at the same time as the sinus augmentation procedure. The inclusion criteria for the placement of the ELSA implant includes a healthy sinus cavity, enough bone around the crest of the implant, enough bone at the apical area of the implant to stabilize the implant. What do we need for immediate rehabilitation of the severely atrophic maxilla to be an option? Well, thankfully, it doesn't change compared to any other full arch reconstruction. The amount of bone remaining doesn't change the requirements. It just makes it harder since there is less bone, and so a higher level of skill is required in order to achieve the minimum implant stability and to have the implants in the appropriate positions. So, for immediate loading, we need stable implants, good mechanics, and a compliant patient. If these three factors are satisfied, the probability of success is comparable to a two-stage rehabilitation plan. For primary stability in the severely atrophic maxilla, it is the engagement of cortical bone that is critical and not the volume of bone. Favourable biomechanics is provided in such cases with a long implant that stretches the posterior support for the prosthesis as far back as possible, as well as a metal reinforced prosthesis during the healing stage. The patient compliance, well, that's the final battle, isn't it? And there's not much more than we can do except educate our patients to avoid eating hard foods and to minimize pressure during sleeping hours with a protective night appliance. To consider an ELSA implant, the following surgical protocol is required. Firstly, raise a full thickness flap to reveal the nasal fossa and lateral sinus. Extend the flap to the tuberosity. Consider an alveolectomy as per your diagnostic workup and gain access to the sinus cavity with a large lateral window to assist in visualization. Mark the most appropriate position for the initial osteotomy on the crest of the ridge posteriorly. Then, develop the osteotomy with the appropriate drill on the residual alveolar ridge and into the medial wall of the sinus cavity with a maximum tilt of 45 degrees to the level of the alveolar ridge. When completing the osteotomy, protect your Schneiderian membrane. Complete your sinus augmentation with your preferred materials, and then select the correct implant length and carefully place the ELSA implant. Proceed to place the desired multi-unit abutment, and your treatment is almost complete. The ELSA implant is capable of achieving 4 zones of cortical stabilization: the posterior occlusal alveolar ridge, the inferior wall of the sinus cavity, the medial wall of the sinus cavity, and the entry to the nasal cavity as shown in the purple circle. Or instead of protruding into the nasal zone, the apical portion of the implant can penetrate the labial wall of the anterior buccal wall, shown in this image in the red circle. You would be surprised that a small pinch of cortical bone can provide the required stability for loading a fixed bridge immediately. The posterior maxillar atrophic ridge classification is a very soon to be published classification to assist a clinician to rehabilitate the posterior atrophic maxilla. The objective of the classification system is to determine available implant options based on the amount of remaining bone following a diagnostic workup and after the final prosthesis design is determined. The three-dimensional properties of the bone in the posterior maxilla are carefully analysed to help decipher what solutions can be predictably provided to achieve favourable stability of the implant. There are 5 classes or groups in this new classification. The classification focuses in the area of the first and second permanent molars. Class 1 is when the bone dimensions are greater than 7 mm in width and greater than 8 mm in height. With this bone, an axially positioned implant can be placed with or without vertical sinus augmentation procedures. For Class 2 ridges, the bone volume is 7 mm or more and the height is greater than 4 mm. For Class 2, the implant options available that will predictably achieve favourable implant stability for loading include an axial implant placement with or without sinus grafting, or the placement of a conventionally tilted implant, the placement of an ELSA implant, or finally, the placement of a zygomatic implant. Class 3 is when the bone dimensions are greater than 7 mm in width and greater than 1 mm in height. When you have this amount of remaining bone, the solutions include, for immediate rehabilitation, ELSA implants or zygomatic implants. The 2 diagrams represent the difference between ELSA implants and tilting conventional implants. When the bone is less than 4 mm in height, a conventional implant is not recommended, since the crest of the implant head is not completely encased with bone and the augmented sinus cavity is not protected. The subcrestal angle change of the ELSA implant allows a sinus cavity to be sealed when the thickness of the crest is as little as 1 mm. This is a critical benefit of the ELSA implant over tilted implants that were never designed to be tilted in the first place. The beauty of ELSA implants is that they extend the clinical indications of tilted implants. The subcrestal angle change allows implants to be placed when the posterior ridge is between 1 and 4 mm in height. If you are faced with a posterior ridge that is 5 mm in width and between 1 and 4 mm in height, then you have a Class 4 posterior ridge. You are probably going to suggest that the only option for immediate loading is the placement of a zygomatic implant in such clinical situations. As an alternative, a predictable option is now the ELSA implant. Class 4 represents the clinical limit of ELSA implant class ridge classification. A horizontal ridge augmentation and a sinus augmentation is utilized to create the required bone architecture to support the implant fixture. Class 5 ridges represent the most resorbed maxillary ridges whereby augmentation procedures would be inappropriate. In these cases, zygomatic implants are the only option for immediate rehabilitation. I would now like the opportunity to present some clinical cases that I have completed over the years, outlining the benefits of ELSA implants in the management of the severely atrophic maxilla with immediate loading. First, for comparison, I will start with a maxillary ridge that is not severely resorbed, that does not require augmentation procedures at the same time as implant placement, nor the use of zygomatic implants. In case 1, we see an example of a patient that has a class 1 posterior atrophic ridge. The patient has been restored with a full arch implant supported prosthesis. No augmentation procedures were required. A prosthesis with no cantilevers was delivered following successful integration. For patients who present with a class 2 posterior atrophic ridge, we have 7 mm in width and a minimum of 4 mm in height. This is adequate bone for a variety of implant solutions that can predictably provide the patient with an immediate fixed prosthesis. In this particular case, an alveolectomy was required in order to deliver a proposed final prosthesis. So even though we have ample bone before the implant was placed, after preparation, the height was reduced. An ELSA implant therefore was placed. As you can see, the flap has been raised, the Schneiderian membrane protected with a collagen membrane, and the implant engages the anterior maxillar cortical bone. The implant has a 24-degree subcrestal angle shift, and a straight MUA, multi-unit abutment, has been placed on the implant fixture. A titanium cylinder has been positioned on the MUA, ready for conversion of the prosthesis. Class 3 posterior atrophic ridges is when it gets a little bit more exciting. These ridges, just to recap, have more than 7 mm of bone width, but 1 to 4 mm of bone in height. They require bone to be augmented into the sinus only, and they do not need any need for any ridge augmentation. For this patient who desired immediate loading, only zygomatic implants were an option to satisfy her concerns. However, we have been fortunate to restore the patient with ELSA implants and bilateral sinus augmentation. Here is another example showing the significant resorption of the posterior ridge, with the thickness of the ridge being 1 to 2 mm. The patient has been successfully restored with 4 implants, 2 implants in the anterior maxilla and 2 implants in the posterior quadrants, resulting in favorable anterior-posterior spread. In this case, the only solution available for immediate loading is zygomatic implants or ELSA implants with simultaneous sinus augmentation. Class 4 posterior maxillar atrophic ridges represent the limit of ELSA implants. In such circumstances, the implants are positioned with simultaneous sinus and horizontal ridge augmentation procedures. With respect to immediate loading, this and only zygomatic implants are the options available for patients when immediate rehabilitation is requested. Patients that present with the most severe and most advanced degree of ridge resorption are classified as class 5 in the posterior atrophic ridge classification, such as what is shown here in this case example. For such patients, zygomatic implants is the implant solution of choice to support a fixed implant prosthesis. The use of ELSA implants at this stage is not indicated. When patients have a very thin ridge, they are usually of advanced age, but not always. And zygomatic implants appear to be the most effective tool to restore functionality with the lowest distress cost. Please review the clinical information presented for case number 1. There is extensive sinus pneumatization extending anteriorly to the canine region, and the anterior ridge is also resorbed. The data shows that there is adequate bone in the anterior maxilla without augmentation procedures. The prognosis of the teeth is poor. The solution to restore function is a full arch implant supported rehabilitation. The patient was provided with conventional implants anteriorly, sinus augmentation and immediate ELSA implants posteriorly to achieve the appropriate posterior occlusal support. If the ELSA implant was not used, then zygomatic implants would have been the only alternative, or tilting conventional implants, but this would not have been providing you with the ideal AP spread that I desire for my patients. The post-operative radiographic image shows the placement of the implant fixture in the augmented sinus cavities. The surgical procedure was completed in a single surgical appointment. The implants have a favourable spread, resulting in a prosthesis that is in harmony with the implant fixtures, which will enhance the probability of prosthetic success and acceptance of the reconstruction by the patient. The before and after OPG images of the reconstruction display the favourable implant positioning and distribution, as well as the clinical images for this advanced reconstruction. Why I consider this case to be advanced is based on the completion of augmentation procedures, implant placement, and immediate rehabilitation simultaneously. All the prosthetic and surgical stages need to be completed to a high level in order to achieve a predictable outcome. We do not need a high volume of bone to achieve the desired implant stability. We need cortical bone. In this case, we engaged the cortical bone of the anterior buccal plate and not by penetrating the medial wall of the frontal maxillary process and nasal cavity. The final ceramic restoration was installed almost 1 year following implant placement. And I tend to delay the fabrication of the final prosthetics in a full arch reconstruction to ensure that I have long-term data on implant, hard and soft tissue stability before progressing to the final stages of the treatment plan. This helps me to maximise the long-term prosthetic stability and success. How many of us would consider the use of zygomatic implants to be the rehabilitation of choice for this patient? The patient has been wearing a tissue-supported prosthesis for a considerable period of time, and the desire of immediate loading with the implants was a driving force encouraging the patient to proceed with the proposed care. The concern with zygomatic implants is that they are more difficult to position correctly in some circumstances, and to position posteriorly as possible. The use of ELSA implants allows maximum AP spread along with the use of conventional implants anteriorly. The top left video image is the preoperative CBCT image. We can see the patient has favourable horizontal ridge width, but thickness of the ridge is lacking. In the posterior segment, you have more than 7 millimeters in width, but about 2 millimeters in height. Following integration and augmentation healing, a final all-ceramic prosthesis was delivered to the patient. Clinical case number 3 is of particular interest. For this case, the patient presented with what seems like a lot of bone in the posterior atrophic maxilla. However, after we designed the definitive teeth, we noted that extensive ridge reduction was required. So the patient was first a class 2 and then ended up as a class 3 in the posterior maxilla atrophic classification. Nevertheless, we were able to remove the periodontally problematic teeth, adjust the level of the bone, and position the implant that engaged the anterior maxilla. Cases which have a good bone width are easily restored with ELSA implants and simplify, in my opinion, the surgical phase of the patient's reconstruction. Managing such cases with immediate loading requires efficiency. If I can complete the treatment under local anaesthetic in my private practice, which is connected to a laboratory, a highly successful and efficient prosthetic and surgical phase can be completed in a short period of time. Choosing solutions that are predictable and reproducible are our key parameters that should guide our implant reconstructions. For this case, it might seem like there is adequate bone for the placement of conventional implants without advanced bone and sinus augmentation procedures. However, following a diagnostic workup, it was apparent that substantial ridge reduction was required. According to the posterior atrophic maxillary ridge classification, this case was a class 3. Following ridge reduction, the thickness of the ridge in the posterior zone was 2 to 4 millimeters, making it more predictable to achieve the required primary stability by placing an ELSA implant that engages the anterior maxilla with augmentation rather than using a straight implant. The use of a zygomatic implant is also appropriate, but escalates the complexity of the work and for the patient to attend a hospital to complete the service under general anaesthetic. A 26mm by 36-degree ELSA implant was simultaneously placed with sinus augmentation. An all-ceramic fixed prosthesis was delivered following successful implant integration. The OPG image for case number 4 shows extensive sinus pneumatization that appears to be pushing into the area of the lateral incisor and canine region. The surgical options are confirmed once the CBCT is acquired. When managing complex cases such as this, we aspire to provide the patient with a fixed solution. However, if the clinical situation does not permit, or if the risk factors are too high, then a fixed solution is not provided immediately. The probability of placing ELSA implants with the appropriate stability is high due to the aggressive apical taper of the implant and also by under-preparing the osteotomy. Following removal of the remaining teeth, the ELSA implant was positioned in the zone of the first molar. The Schneiderian membrane was repaired following a tear. The sinus was augmented with a combination of xeno and autogenous particulate graft material. The ELSA implant engages the cortical bone of the frontal process of the maxilla, which can also be described as the cortical lateral wall of the nasal cavity. Patients suffering from chronic illnesses or with a history of trauma can often have higher rates of dental disease, and as such, patients who present with significant degree of breakdown. The contributing factors to the dental deterioration go far beyond a lack of plaque control or a diet high in simple sugars. Subsequently, when managing such patients who have suffered, the clinician needs to be mindful, to be empathetic and understanding to promote a positive psychological, systemic and dental health outcome. My patient Paul here had the defective dentition removed, followed by the placement of 6 implants with favourable AP spread. The single surgical appointment, when appropriate, is beneficial for many patients. After successful integration, an all-ceramic definitive implant-supported prosthesis was provided to the patient. Patients who carry trauma and dental phobia consider the advanced treatment plan to reduce the number of surgical appointments very encouraging. It can be a motivating factor for a substantial number of patients who wish for the dental rehabilitation not to interfere with their quality of life for too long. In clinical case number 6, the patient presented with a severe vulnerability to periodontal disease. Not only did he have a suspected genetic vulnerability to periodontal disease, but he also suffered from dental phobia, was a smoker, and presented with a compromised degree of plaque control. Following a suitable control phase to stabilize the periodontal tissues, the surgical management of the maxillary arch commenced and involved the removal of the maxillary dentition, followed by implant placement and augmentation procedures simultaneously. Crestally, machined ELSA implants, shown here, were placed, which is another specialized line of ELSA implants available for suitable patients with a suspected elevated risk of crestal bone loss due to biological pathways. Following removal of the maxillary teeth, the first permanent molar zones were considered most appropriate for immediate implant placement. The implants satisfied the surgical requirements and the prosthetic requirements. Specifically, we achieved favorable primary stability and the correct maximum AP spread for optimal biomechanical stability, along with the appropriate implant dimensions, connections, number and substructure material properties. After a year of provisionalization, the patient was fitted with an all-ceramic definitive prosthesis. Once the infected teeth were removed, the first permanent molar zones appeared to be the most appropriate location to commence placement of the ELSA implant. The ELSA implant transversed the sinus and engaged the nasal bone. The implants were 26 mm and had a 24-degree subcrestal angle change. The appropriate stability of the implants were achieved, and subsequently a fixed immediate implant prosthesis was provided to the patient on the same day. Clinical case number 7 presented a patient in his 50s who presents with a previous tooth-supported reconstruction which now shows evidence of deterioration and breakdown. The patient suggests an interest to avoid a removable appliance during the healing period. The posterior maxilla atrophic classification is class 3. The bone height is less than 4 mm and the width is favourable enough so that horizontal ridge augmentation is not required. The options to satisfy the patient's concerns with respect to posterior support include ELSA implants or zygomatic implants. ELSA implants aid to reduce the workup for the patient. The treatment can be completed in a single dental visit in the private clinical setting. When patients present with favourable bone volume in the anterior maxilla for the placement of conventional implants, it makes it beneficial to consider ELSA implants. When the anterior ridge requires extensive grafting, then zygomatic implants are probably more likely to be required. Following acceptance of the treatment plan, the problematic teeth were removed and the sinus window and location of the crestal implant position was prepared. The dental implants are placed simultaneously. Entry into the sinus was completed and the augmentation phase was completed simultaneously. The implant transverses the sinus. The sinus membrane is elevated extensively on the medial wall in order to prevent the osteotomy drills from damaging the sinus membrane during its preparation. On the contralateral side, the collagen membrane is fixated to the medial wall of the sinus cavity. The pins help maintain the correct position when carefully placing the particulate graft. The membrane covers the large sinus window to stabilize the graft material. Case number 8 is an exciting case. This case shows the use of a variety of implants available in the southern implant range. I have utilized deep conical connection, external hex, ELSA and coaxial implants with different angulations. Following the removal of the teeth, we can see the accentuated angulation of the osteotomy drill. The implants receive the majority of their stability by engaging as little as 3 mm of cortical bone in the anterior maxilla. The engagement of 2 to 3 cortical plates located at the crestal wall, the medial wall of the sinus, and the lateral wall of the nasal cavity or frontal process of the maxilla allows high implant stability with very limited bone quantity. Number 9 was a very challenging case surgically and represents what I think is the current limit of what ELSA implants can predictably rehabilitate. The patient presented with the numerous risk factors and quality of life concerns, making it challenging to provide her with zygomatic implants. The patient presented here clearly understands that she is in need of professional dental care due to the ongoing odontogenic infections. When I discussed the opportunity not to have a removable appliance during the healing period and to have all the surgical stages to be completed in a single appointment, she was certainly encouraged and proceeded with the proposed care. 4 zones of cortical bone adequate to stabilize dental implants was selected. The patient was rehabilitated with a fixed metal reinforced prosthesis. Long implants that could engage the anterior maxilla and still allow proper posterior prosthetic support were used. The cortical bone of the anterior maxilla provides the appropriate stability for the implants. The 24-degree angled implant was all that was available at the time, and this was completed. These are the clinical surgical images relating to case number 9. The teeth were removed, sinus membrane raised, implants placed followed by stabilization of the augmentation with a collagen membrane. Aim to secure the sinus augmentation with tacks and pins. I call this the pouch technique. This is completed by using a 30 by 40 mm collagen membrane. Secure it to the medial wall of the sinus cavity and fold it in such a way to make a pouch. Place the graft material and then fixate the membrane. With this technique, you often can complete a horizontal ridge graft at the same time as a sinus graft with the same collagen membrane. Case number 10 is the final case that I will present to you. My patient presented with partial edentulous and required a solution to eliminate the need of the removable prosthesis. The prognosis of the remaining teeth was fair. However, the strategic value of the teeth when discussing the different options with the patient was deemed to be low, and subsequently they were removed and a full arch implant supported reconstruction was considered to be in the patient's best interest. In the upper left posterior quadrant, horizontal ridge grafting was completed as well as sinus and implant placement. The upper left quadrant was a class 4 posterior atrophic maxilla, and there was not enough bone on the buccal, so increasing the bone thickness was necessary. The post-operative OPG shows a fixed provisional appliance, favourable AP spread, and implants positioned correctly so that there is an elimination of cantilevers. Apical coronally but also buccal lingually. I have been documenting the placement of ELSA implants in my clinical practice since 2017. In 2021, my team and I ran a retrospective study to assess the outcomes of the implants utilised in full arch immediate reconstruction after 3 years in function. 37 patients were included in the study. 187 implants were placed, and of which 73 implants were ELSA implants. After a 3-year period, 21 ELSA implants attended for their follow-up. For all the cases included in the study, the posterior maxillary ridge classification was class 3 or 4, meaning that if an ELSA implant was not utilised, then the only other option for immediate loading for the patients would have been zygomatic implants in the posterior zone. Despite the lower volume of bone and advanced atrophy of the maxilla, 75% of the arches were rehabilitated immediately within 72 hours. One of the hypotheses of the study was to determine if the ELSA implant could be considered as an alternative to the placement of zygomatic implants for the severely atrophic maxilla. After a 3-year period, the survival rate was 92%. All failures so far have been documented to have occurred after a short period from implant placement and all within the first year after placement. Patients of advanced age with risk factors to implant failure were all included in the study. The plausible causes for the earlier failures were sinus augmentation failure, infection and overloading of the implant fixtures. Once successful integration was achieved, no further surgical or prosthetic failure has been noted. The research has been accepted for publication. From this retrospective study, it has been promising to document ELSA implants to have a cumulative survival rate of 92% after 12 months and 100% on the subsequent years. The survival rates and outcomes from this study was consistent with other published data involving tilted implants with or without sinus augmentations and zygomatic implants. The study also shows that the crestal bone around the implants was consistent with other published data. The time has now come to finalise my presentation, and I have truly appreciated the opportunity to present my research and clinical cases to all the ICOI members.